First of all, I would like to thank the European Hematology Association for giving us an opportunity to provide an overview of these data, and I'm presenting this work on behalf of Spark Therapeutics, where I actually work now, and our colleagues at Pfizer, who are partners in this work, investigators at the Children's Hospital of Philadelphia and at the University of Mississippi Medical Center, and Dr. Spencer Sullivan of the University of Mississippi Medical Center will be presenting the data this afternoon. So I've been working in this field for about 20 years, and it gives me great pleasure to say that I'm finally happy with where the results are. So hemophilia is an X-linked bleeding disorder caused by a deficiency of either factor IX, which is called hemophilia B, or factor VIII, hemophilia A, and the work today is about hemophilia B. The disease is characterized by recurrent bleeds into the joints, and on the bottom picture there, if you've never seen a joint bleed, this is a little boy with an untreated bleed, and you can see that the joint expands until it fills with blood, and the back pressure from the bleed finally pinches off the vessels and the bleeding stops. The most famous sufferer of hemophilia B is shown in the picture above, Alexei Nikolaevich, the last heir to the Romanov throne, who ironically did not die of hemophilia, but of the events of the Russian Revolution. The largest category of patients are severely affected and have less than 1% normal levels of factor IX, but patients with a modest increase into the range of 1 to 5% are moderately severe, and those with levels above 5% of normal are only mildly affected. And currently we manage hemophilia by intravenous infusion of clotting factor concentrates anywhere from 3 times a week to once every 10 days or so for extended half-life products, but patients are maintained on these intravenous infusions for life. Previous work in gene therapy has been shown to achieve levels in the range of 5 to 7%. These were data published by Amit Nathwani at the University College London. But to achieve those levels required a dose that also elicited an immune response to the vector and required a brief course of steroids for 4 out of 6 patients who received that dose. Now, the work that's going to be presented today involves a novel vector that we developed at Spark. First of all, it has a novel bioengineered capsid, and this is the first test of this capsid in human subjects. And it drives, under the control of a liver-specific promoter, a factor IX variant that encodes a high-specific activity factor IX species. And so the trial itself involves intravenous infusion over a period of about 1 hour of this vector in a saline solution. So the phase 1/2 study that's being presented is in adult males with severe hemophilia B, severe or moderately severe hemophilia B, and the primary goal of the study is to evaluate the safety and tolerability of this novel factor IX vector. The hypothesis of the work was that if we could engineer a vector efficient enough, we would be able to infuse it at a dose low enough that it would drive levels of expression greater than 12% of normal, which in previous work has been shown to be associated with an absence of joint bleeds in natural history studies of people with mild disease, and that infusion at a low dose would eliminate the need for any type of immune suppression with steroids. So the subjects that are being presented today range in age from 18 to 47, and the dose that was infused was 5 times 10 to the 11th vector genomes per kilogram of body weight. And we followed factor IX activity levels, liver enzymes, bleeding episodes, and factor usage over a period ranging from 7 weeks to 26 weeks or 6 months after the vector infusion, and the results are shown here. So as you can see in the graph on the right, I think one of the most remarkable features of the data in my mind has been a very consistent performance among the 4 subjects infused thus far. There's a gradual rise in circulating levels of factor IX into the range of 27 to 39% among these 4 individuals. It takes about 8 to 12 weeks to come up to the plateau. None of these individuals have shown any evidence of an immune response that would require treatment with steroids. All of the subjects are completely off prophylactic infusion of factor IX. And during the course of the follow-up, there has been only one subject who infused himself once, and that was an individual who treated himself 2 days after vector infusion for a suspected ankle bleed. Now, all of these people get brought up to 100% at the point when they're infused, so the likelihood is that 2 days after that, he still had a good level on board. But anyway, you know, his instinct when he has ankle pain is to treat himself, and he did so. But other than that, none of these subjects have infused clotting factor since they were administered vector. So I'll just conclude by saying that the data to date suggests that a single intravenous infusion of this AAV vector encoding a high specific activity variant of factor IX at a low dose, 5 × 10 to the 11th vector genomes per kilogram, is driving factor IX activity levels in the range of 25 to 39%. This is the lowest dose that I know of that has been used, and is achieving factor IX activity levels well in excess of the 12% of normal that we know to be effective in preventing joint bleeds. And that these levels of factor IX activity are likely to be effective in keeping people free from bleeding. All of these participants have discontinued factor replacement without experiencing spontaneous bleeding episodes. None of them have required immune suppression, and observation is ongoing, and we're expanding the trial. So thank you very much for your attention.